Thank you so much, sir. We'll now move on to the next academic session. This is on Immuno-Oncology and Cardio-Oncology. And I invite our chairperson, Dr. Suvru Banerjee, Senior Consultant Interventional Cardiologist at Apollo, Kolkata. Welcoming sir to the stage.
So good afternoon, and thanks for the invitation. I think we are running probably almost an hour late, so without much prelude, let me just crack on. And the first speaker is Dr. Nandini Menon. Could I request Dr. Menon to give her talk? She is the Professor, Department of Medical Oncology at Tata Memorial Hospital, Mumbai.
Good afternoon, everyone. And I would like to thank the organizers for this opportunity. So today I'm going to be discussing two papers which are the recent published meta-analysis on cardiovascular immune-mediated adverse events, and there's a retrospective study also on cardiovascular adverse events. So these are the three papers which looked at cardiotoxicity in patients who received cancer-related immunotherapy. Two of them are meta-analysis and one is a retrospective study. So in interest of time, I'll just quickly go to the first study, which was a Chinese study from Chengdu, China. It is a meta-analysis of 101 randomized controlled trials across the globe. So these trials were selected, and they looked at the three main events that occurred, that is myocarditis, pericardial disease, and arrhythmias. And they also looked at the relative risk of cardiotoxicity, comparing the patients who received immune checkpoint inhibitors versus those who didn't. So the groups that they looked at was the tumor type, the type of immune checkpoint inhibitor, and what combinations were used. This is how they did the meta-analysis based on the PRISMA guidelines. And what they noted was, the slide is very busy, but just to summarize, is that the experimental is the experimental group of the trials that they included, the 101 studies, which had immune checkpoints as part of the treatment. Control was the control group, which generally had either a placebo or chemotherapy, depending on the scenario for treatment. And overall, the incidence across trials was 3% in the experimental and 2.3% in the control. The incidence amongst those who received anti-PD-1 among the checkpoints were around 3%, anti-PD-L1 was 2%, and there seemed to be a slightly numerical higher incidence amongst those who received anti-CTLA-4 agents. What is important to note is that if you received an immune checkpoint inhibitor, the risk of all grade cardiotoxic events, that is pooling all the cardiac events of all grades, was higher. The relative risk was 1.3 with a low heterogeneity I-square. So this is an important finding from this meta-analysis. Moving on, the other important thing what they noted, and it was that all groups, that is PD-1, PD-L1, and whether they received, so the type 1 and type 2 in their studies is where they grouped studies into those which just looked at immune checkpoint inhibitors alone compared to placebo or chemotherapy, and type 2 were immune checkpoint combinations, either immune checkpoint with chemotherapy or immune checkpoint with a targeted therapy in the experimental arms. So this is what they found the relative risks in these various subpopulations. But what was not explained but was noted in the studies were the trials that did not have lung cancer and melanoma, that is a non-melanoma cancer group. In this meta-analysis, they seem to have a higher relative risk of cardiotoxicity. Myocarditis is one of the events that they looked at. The relative risk overall was 1.79. It was significant. Arrhythmia is the next event they looked at, which was also significant. Pericardial events did not seem to be significant in this meta-analysis, including 101 trials. They saw patients of myocarditis, they had some differences in patients who received anti-PD-1 drugs and those who received the type 1 of ICI combination, that is ICI compared to placebo alone. In the other two events, that is arrhythmia and pericardial events, they did not seem to see this pattern. Immune checkpoint inhibitors overall was associated with a higher risk of arrhythmias, but there is a catch. When they did a sensitivity analysis looking at the results for pooled relative risks by removing individual studies and looking at it, they saw that this was not significant when they did sensitivity analysis. So this data, that is the interpretation of the increased risk of arrhythmias in this meta-analysis, has to be kept in mind with this caveat. So to summarize, this meta-analysis by Zhu just highlighted three things. That is, cardiotoxicity is increased in those who received immune checkpoint inhibitors, although the overall all-grade incidence is low. It's around 3%. Myocarditis is definitely increased. PD-PDL1 and CTLA4, all of them seem to have a higher relative risk. However, the slightly higher risk of CTLA4 compared to PD-PDL1 for myocarditis could be because of confounding factors, because the authors then also did a meta-regression which at that time showed that CTLA4 particularly did not increase the risk over an anti-PD1 or an anti-PDL1. So this is something that they pointed out. Pericardial events in this particular study, unlike the other study which I'll present next, did not have an increase with immune checkpoint inhibitors. And arrhythmias had a higher relative risk. However, sensitivity analysis showed a non-significant relative risk. A similar meta-analysis, this time looking at again randomized control trials and some observational studies. This was done in the United States. So they again, this is the PRISMA guidelines that they followed and the process which ultimately led them to select 54 randomized control trials and 24 observational studies. So OS are the observational studies. So if you look at the forest plot, this is for the myocarditis and pericardial disease events which they had described. So 37 trials and 19 observational studies reported these events. Many of them do not report, but these were the events that were reported, 38 for myocarditis, 49 for pericardial disease, and observational studies reported around 6,000 and 10,000 for the same respectively. And across the board, if you look at the plot, you can see that the incidence or the odds ratio for patients to develop myocarditis and pericardial events, which is shown below, seem to be higher in those who received immune checkpoint inhibitors. So the odds ratio was 3.5 for myocarditis and it was 2.73 for pericardial disease. There were few studies that had a publication bias, and when these were adjusted, here the odds ratio for pericardial disease didn't seem to be significant, but myocarditis did not have any publication bias and it was significant across multiple randomized control and observational studies. Similarly, in the observational study, there was no significant increase in risk for myocarditis and pericardial disease, but what the observational studies noted was that combination immune checkpoints seem to have a higher odds ratio for the risk of myocarditis, not for pericardial disease. They also looked at myocardial infarction and stroke. Stroke, they did not seem to find an increased risk with immune checkpoint inhibitors, but there was a borderline association between the immune checkpoint inhibitor use and myocardial infarctions in the randomized control trial pool, which was borderline for significance, but when they again removed two heterogeneous studies, it became significant. The observational studies did not seem to show an additional increase in risk for myocardial infarctions. So just quickly, just compare these two. The Zhu et al. Paper looked at only randomized control trials. The others looked at observational and randomized control. Both showed that immune checkpoint inhibitor use has an increased risk of myocarditis. In Zhu's paper, there was no significant increase in pericardial events, which is contrasting to the other meta-analysis where there is some indication that pericardial disease may be higher, especially as the authors discussed in patients with lung cancer where they may have other risk factors like prior radiation to the chest and other factors. Arrhythmia, some indication in the Zhu et al. Meta-analysis was not reported by the other meta-analysis. And MI seems to have a borderline association with the use of immune checkpoint in the analysis by Sharma, but was not reported in the others. So this is just the comparison. Overall, both meta-analyses highlight that myocarditis and pericardial disease are increased, and we need more data to, I think, dissect out which of the patients at higher risk. Since we are out of time, the third paper, I'll just give you the highlight of the paper. This was a retrospective analysis of patients who were at Brigham's General Health System in Massachusetts. They looked at patients who had suspected myocarditis. The main goal was to look at the mortality, 1-year cardiovascular mortality, in patients who had severe versus non-severe. So they looked at how the severity of myocarditis impacted survival and other all-cause mortality, cardiovascular readmissions, left ventricular EF over a period of time, and whether ICI immune checkpoints were re-challenged. So severity was based on ICOS criteria. So those who had hemodynamically instability, heart failure, required ventilation, had heart blocks or arrhythmias were labeled as severe. Those who met the criteria for myocarditis without these were non-severe, and those who did not meet the ICOS criteria were negative. So the main thing is this graph, which I'll just summarize. Patients who had severe myocarditis, 1 year cardiovascular mortality was worse, much far higher. The hazard ratio was 6.5 if you had severe versus if you had non-severe. However, the all-cause mortality was similar amongst this group. This is the same graph. What they also noted is all the biomarkers are far higher in the patients who develop severe myocarditis as compared to those who have non-severe. And again, the graph on the right shows all cause, and the graph on the graph on the left, which is A, shows the all cause mortality, B shows the readmissions, which again are higher in the patients who had severe myocarditis, and the graph on the extreme right again shows re-challenge, that once you have suspected myocarditis in their data set, even if the patients had negative or non-severe, the incidence of re-challenge is quite low. It was overall only 17%, and that's the concern. So this is a summary. 1 year cardiovascular mortality will be higher if you have a severe clinical presentation. Non-severe generally has much more benign course and may have a comparable cardiovascular mortality with those who do not have myocarditis. 1 year all-cause mortality seemed to be high in patients, all patients with suspected immune checkpoint myocarditis, which is what we need to understand, that even though the non-severe did not have a high 1 year cardiovascular mortality, the all-cause was worse, and a small number only ended up getting re-challenged with immune checkpoint. So thank you, and I'm sorry for exceeding my time.
So thank you, Dr. Menon, for a very informative talk. And I'm sure there would be a couple of questions. Could I ask you the first question? You did mention in the last analysis of the paper that the patients with severe myocarditis, they have a higher mortality, and so I'm sure you're going to follow them up, if it may not be with the non-severe ones. So how do you follow them up, and what would be your frequency of follow-up in such cases? And the second question, if I can ask you here, the second question is, you did say like the cardiovascular mortality was less, but the total mortality didn't differ. So does that mean that this patient died of something else, maybe because of the cancer itself, or so how do you explain that?
So probably, so that's what, I'll take the second question first. The all-cause mortality seemed to be similar amongst all of them. So if the particular cardiovascular mortality was much lower, why should those who had non-severe die? So I think the retrospective study also highlights in their next slide that the re-challenge was very low. So did the clinical suspicion of myocarditis prevent those patients from receiving immune checkpoints where they could have probably be re-challenged, or even other therapy? That is what the authors have actually not discussed in the paper as to why, I mean, how many percentage of patients did end up in those who did not receive and could have received what kind of cancer, subsequent anti-cancer therapy they received, which could have impacted the all-cause mortality. Because even in our clinical setting, once we are concerned that there's a EF drop and you don't know what to do, I mean, the re-challenge risk is something, the threshold to re-challenge is quite high. We don't generally re-challenge. So those could impact outcomes, especially if the patient is a palliative disease, aggressive disease. So that could be the possible cause. Here they did not mention that the follow-up of, what was the follow-up of severe was not looked at. They just looked at the difference in the biomarker patterns. But we generally, if we have severe myocarditis, we follow them up with the TROPA and NT-proBNP and an echo every, like initially once they are discharged after 4 weeks, and then every 3 monthly. But our incidence of severe, the problem is that the awareness of picking up myocarditis has started coming now with the learning curve of medical oncologists also learning how to pick up the rarer toxicities, because pneumonitis, colitis is pretty common, and we do pick it up. The severe ones anyway present with cardiac symptoms, and then they are referred to a cardiologist and get managed. It's the asymptomatic ones which have a drop of EF. So then it's a little bit of a gray area, because we have not actually started putting the Western world has like already put it in place. We don't have a system to screen patients now, and slowly we are starting to do it. We do an echo ECG because usually these are given in combination with chemotherapy, so you do an echo ECG as a routine practice. But an echo ECG, probably TROPI and an NT-proBNP should be used as screening tools, especially in those who have other cardiovascular risk factors, so that we can at least screen the high risk. So we are slowly starting to incorporate this into our practice as well.
So thank you. And any other question? Microphone, please. Could someone give him a microphone, please?
we have really learned a lot by treating with immunotherapy. First time when the treatment was introduced, there was no adverse cardiac event reported at all. So it was supposed to be without cardiac side effects. But what happened in the next 2 years was that a significant number of people died of myocarditis. Many of them developed complete heart block. Many of them developed VT. And the death rate in the patients who had severe symptoms and also had complete heart block or VT was about 96%. Then we started realizing there is a problem. The classic statement was those patients who develop severe myocarditis, unless they receive at least 800 milligrams of methylprednisolone bolus dose daily for minimum 3 days, the chances of them surviving is 0. At that point of time, ESC came up with saying probably we'll have to ban immunotherapy. And from then, now we learned from our way how to treat a patient with immunotherapy. Now our surveillance became better, so the mortality really came down. Now we say there is no immunomyocarditis. I don't agree to you the statistics. Actually, with one agent, the chance of immunomyocarditis is 0.4 to 0.5%. With 2 agents, it's about 1.4 to 1.5%. That was something which has come down significantly. And as you clearly said, only 17% of the patients who didn't have actual immunomyocarditis, were merely suspicion, were only rechallenged. So our learning of how to deal with this has really made big difference. That's how now more than 50% of the cancers are treatable with immunomyocarditis. It's an excellent presentation. Nice.
Thank you. Thank you, Dr.
Thank you,
Menon. I think let's move on to the next talk by Dr. Nivedita Sen. She's a senior resident in medical oncology at Narayana Super Specialty Hospital in Kolkata. Dr. Sen.
Good afternoon, everyone, my teachers and my colleagues here. Today, I'll be talking regarding the cardiovascular immune-related adverse events with immunotherapy along with anthracyclines in breast cancer. So, at the outset, we know that triple-negative breast cancer, which is defined as the ER, PR, and HER2 negative, it is which is approximately 15% of the total breast cancer and is considered as one of the aggressive type. And it is highly heterogeneous and have a poor prognosis. Modern therapies, they are improving the survival, and each of the treatment component, that is the anthracyclines, the immune checkpoint inhibitors or the RT, they can independently cause the cardiac toxicities. Hence, they can increase the cancer therapy related the cardiovascular toxicity risk. So here comes the role of cardio-oncology, which provides a holistic management for the cardiovascular risk across the cancer care. So the standard therapeutic landscape for triple-negative breast cancer includes the neoadjuvant therapy in the form of, for non-metastatic disease. It includes neoadjuvant therapy with the chemotherapy along with the immune checkpoint inhibitors, followed by a surgery where BCS is preferred and its outcomes are comparable with a mastectomy, followed by, if there is no pathological complete response, we can consider capecitabine adjuvant or PARP inhibitors in case of BRCA positive patient along with radiotherapy. And in case of metastatic disease, it is mostly the systemic therapy in the form of chemotherapy along with the immunotherapy in the first line setting, followed by the ADCs in the later lines. So if you look at the mechanism for the cardiotoxicity of the anthracyclines, there are three major pathways. The first one is the DNA damage pathway, where the doxorubicin, it intercalates with the DNA, inhibits the topoisomerase 2B enzyme, and it causes the double-strand DNA breaks, and which activate the p53 and causes the apoptosis. On the other way, there is an oxidative stress pathway, where the doxorubicin which is reduced by NADPH, cytochrome P450, and it causes the production of various ROS accumulation and causes oxidative injuries to the lipids, proteins, and the mitochondrial DNA. And there is an iron-mediated toxicity as well. So this all three pathways leads to mitochondrial damage and apoptosis, leading to cardiac dysfunction. Whereas the immune checkpoint inhibitors mediated cardiotoxicity, they have a different mechanism of action. Mostly it is by the T cells. The T cells, which is by the immune checkpoint inhibitors, they causes activation of the CD4 and the CD8 T cells, which causes direct damage to the cardiac myocytes, as well as there is a normal physiological protection by the PD-1 receptors, which is also lost. And there is release of various cytokines such as TNF-alpha, interleukin-6. They causes the cardiac toxicities. And there is hypertension, there is damage to the, there is atherosclerosis, which in turn produces the ischemic heart diseases, the myocardial infarction, as well as there is conduction abnormalities in the form of arrhythmias. And there is pericarditis leading to pericardial effusion and tamponade, and there is ultimately cardiomyopathies and heart failures. So is there any possible synergism in the mechanism of both the anthracyclines and when the anthracyclines are combined with the immune checkpoint inhibitors? So there are few probabilities that and possible synergistic interaction is there, where we can see that at the cellular injury level, the anthracycline causes the ROS generation, and the immune checkpoint inhibitors, they causes the T cell mediated cytotoxicities. So the damaged mitocyte, they release the DAMPs and they amplify the immune recognition. And if there is a pre-injured myocardium, which becomes immunogenic, so there is a autoimmunity which is triggered. And also there is a cumulative myocardial dysfunction, lowered repair threshold, so there is accelerated apoptosis, and there is combined microvascular ischemia as well. So there is increased chance of troponin leak. So there are three papers I'll be discussing today, which are looking at the possibilities whether there is any synergism between the mechanism of cardiotoxicity. So the first paper was regarding the cardiovascular toxicities in patient with triple negative breast cancer receiving the treatment with chemotherapy and immunotherapy. So it was a retrospective trial which enrolled 37 patients, and among them 13% had a prior anthracycline exposure. What they found in the paper that the early troponin rise was often seen within the first 1 to 2 cycles, and there was mild LV dysfunction which may precede the symptom. And rare myocarditis may happen, but it is potentially fatal and mostly it is unrecognized. So what they found that there was high incidence of subclinical cardiotoxicity. There is troponin raise with mild CTR-CD. So we can see that the chemotherapy-related cardiac diseases were among them. There was the highest incidence was the troponin increase, which was found in approximately 44% of cases. Myocarditis was seen in 5.4%, and the any cause cancer-related cardiac damage was seen in 25% of the patient. So this study suggested that there is a possible synergistic cardiotoxicity from anthracycline and immune checkpoint inhibitor combination. So the second study, they look at the dynamic cardiac changes in low cardiovascular risk patient with triple negative breast cancer treated with chemoimmunotherapy. So the study objective was to assess the early cardiovascular changes in TNBC patient treated with pembro along with chemotherapy, and they evaluate the incidence of more than equal to grade 2 CTCAE events. They look at the dynamic ECG and the echoes and associated, if there is any role of associated radiation dose as well. So it was a retrospective single center study which included 85 patients with early stage triple negative breast cancer, and the primary endpoint was the incidence of more than equal to grade 2 CTCAE cardiac events, and the secondary endpoint was the ECG and the echo changes. So this study found that approximately 10% of the patient had more than equal to 2 grade 2 cardiac events, and the median time to event was 7.3 months, and the 1-year cumulative incidence was approximately again 9.6%. And the ECG finding, they found that the QTC prolongation was seen in approximately 40% during the treatment versus 15% which was present in baseline. And there was a slight increase in the heart rate. And these changes, they were largely resolved without any active intervention, and post-treatment they resolved. And there was no new persistent arrhythmias. In the echo also, grade 2 ejection fraction decline was seen in 5 patients. Among them, 3 were recovered, and there was moderate diastolic dysfunction was seen in 25% of the patient. And there was no significant changes in the other parameters, such as the decline in the ejection fraction, GLS, or the pulmonary artery systolic pressure. So they concluded that the early cardiac toxicities, which was found in approximately 10% of the patient, even in low risk young cohort, and those who received the radiation, the LED radiation exposure correlated with the cardiac risk. And the QTC prolongation and the diastolic dysfunction were the early detectable markers. The third study, they look at the investigations of cardiotoxicity with the concomitant use of anthracycline and the checkpoint inhibitors. And the objective was to assess the incidence and the characteristics of the cardiotoxicity in triple-negative breast cancer patient treated with anthracyclines and pembrolizumab. It was also a retrospective study which included the stage 2 and 3 TNBC cohort, and cardiotoxicity was defined as decline in the ejection fraction by less than 40% or LVF with less than 50% with a more than 10% drop. They found that only 2 patients among the 49 patients developed the cardiotoxicity. The first one, that patient had a drop of ejection fraction, and the second one had developed myocarditis, which eventually developed cardiac shock, and there was a death. So they interpreted that the combination therapy shows a lower than expected cardiotoxicity, and anthracyclines may sensitize the myocardium to the immune injury. And early chemo monitoring is the key for the subclinical dysfunction. So this is the European Society of Cardiology guideline of 2022, which showed how the grade severe IRAs should be managed. As we are running out of time, I'm not going into the detail. And I think this should be the approach of our, sorry. Sorry, I'll just quickly go through the last one. So I think there is 5S, which should be, I think it will be an appropriate approach to screen the patient, to surveil through the entire during the course of treatment, suspend the ICI during if there is any cardiac event or if there is any increase in the biomarker, suppress, that is the treatment with glucocorticoids and the second line ATG, MMF, infliximab, and also give the light support and tailor treatment according to the cardiac function. So a monitoring of the regular assessment is essential. A baseline assessment with ECG, LVEF, GLS, troponin, BNP is required. And during treatment also, ECG and troponin should be measured, and echocardiography should be done at regular interval. So the take-home message is that all these study, they emphasizes on the importance of cardio-oncology surveillance during the TNBC therapy, need for multimodality cardiac monitoring, optimize the LAD-sparing radiotherapy, implementation of the guideline-based cardiac surveillance, and investigate the anthracycline-free regimens and the biomarkers of cardiotoxicity. Thank you all, and thank you Asian Cardio-Oncology Society for giving me this opportunity. Thank you.
Thank you, Dr. Sen, be careful, for the great talk. And if there is no other question, oh, there's one question. Okay.
Hi, sorry, Aruni here again. Sorry for irritating. When we talk about ICI-related myocarditis and we talk about biomarker surveillance, we would do serial troponins for biomarker surveillance. And my question to you is, troponin I or troponin T or both or any of them? Is there any superiority of troponin I over troponin T, or is there a superiority of TROPs in ICI-related myocarditis? And I have a second question after you answer that.
So ideally it should be that both the things should be done, but in our regular practice, we generally do troponin I first, and then we go for, we prefer to do troponin I over the troponin T.
I think your question is something based on, there is a definite difference. Patients who have a troponin I positive will have more myocarditis. If it's troponin T, they will have myocarditis with a skeletal myositis. They have more arrhythmias and more death. So if it is troponin T elevation, that means patient is more sick, needs more attention. Of course, there are other markers. Between these two, this is the difference. Troponin I increase and NT-proNP elevation means more cardiac dysfunction, death rate is lower. But troponin T elevation, less myocarditis, but significant myocarditis, cardiac arrhythmias, skeletal muscle involvement, especially with thymic tumors. Death rate is more.
And there is some temporal difference as well, I believe, in the rise
Yes,
and fall.
troponin T elevation actually happens earlier than troponin I. Troponin I comes later, but troponin I is more specific for myocarditis. Troponin T is less specific, but is more sensitive.
So thank you, Dr. Sen. I think it was a wonderful talk, and let's
Thank you.
move
Thank
on
you
to
so
the next speaker, Dr. Shirish S. Alurkar, and he's the head Department of Medical Oncology at HCG Astha Cancer Hospital, Ahmedabad. His talk would be on risk factors for cardiovascular immune-related adverse events.
Thank you, Chairperson. And over the last few hours, maybe 6 hours, we have been hearing a lot of cardio-oncology. I think Vivek will have a big job to do at the end of the conference, assimilating all these presentations using AI, as Dr. Purvi said, and give us some sort of inputs at what is the basic conclusion of this conference here. So I have been asked to dwell a little bit on the risk factors for immune-related CV events. Not very, most of them are very well defined. As you can see here in the European Society Cardiology, European Cardio-Onco Society, they define basically 5 types of cardiac toxicities. Starting from the left, the cardiac dysfunctions, arrhythmias, hypertension, and vascular toxicities. Of most importance, and which is more frightening, is the one on the right or top, that is the myocarditis with a very high mortality. I think Dr. Nandini also mentioned a high mortality, about 40 or 50%. Sometimes some trials or some studies have shown as high as 60%. So that is one thing which you really have to catch in very early stages. When you have some sort of cardiac toxicity, you have to look for myocarditis specifically based on various cardiac enzymes and various methods. So I will not go into the detail of that. But they have variously defined how to check this myocarditis based on the Bonacca's criteria. I think cardiologists are more tuned to it. We are not very much tuned to it. There's a definitive way of defining based on the pathology, which is the gold standard. And of course, you have to correlate with the cardiac MRI. Most of the in clinical practice, and I was discussing with someone in the morning today, that in India, most of them, I don't think go in for a myocardial biopsy because of various reasons. A patient is too sick. The cardiologist is not ready to put in that, the biopsy needle or whatever you call it, and get a biopsy. So most of the cases are basically based on the MRIs. That's a practical consideration, although the guidelines say that the biopsy is the gold standard. The risk factors, most of them are known to all of us. The age, higher the age, more the chances of developing cardiac toxicities, diabetes, coronary artery disease, blood pressure, a history of congestive heart failure, patient having a history of myocardial infarction, a type of cancer which I will show you in the next few slides. They're all correlated with a development of better chances of developing toxicities, especially cardiac toxicities. A very discordant data, whether a single agent or a dual agent causes toxicity. But as a general rule, if we are using a dual agent, a dual IO, ipilimumab plus nivolumab, say for renal cell carcinoma, we have to be a little more watchful because these are usually elderly patients. They usually have some comorbidities, and we expect a higher degree of cardiac toxicities. IO plus chemotherapy, of course, the previous speaker did mention, and we have IO plus targeted therapy, which we use, for example, in hepatocellular carcinoma, where the incidence is slightly also higher. And of course, the duration of use. So I think this was covered in some of the speaker. This was a risk factor, a scoping review to see which are the various risk factors, and they have defined 60 risk factors and divided them into 3 broad categories. The 25 of them are the common risk factors. 5 of them are what is known as the traditional risk factors, which we are all used to them, and others are the very specific related to the cancer. So what they found out that the commonest tumors were the lung, melanoma, and renal cell carcinoma. Of course, this is the Western data. So in India, probably we should have in head and neck there, but we don't have much data for for the head and neck because a lot of immunotherapy is being used for head and neck in India. Commonest toxicity is myocarditis as high as 60%, and followed by heart failure and some arrhythmia, which is about 38%. When does the cardiotoxicity occur? So you should be very careful. As soon as the first dose is given, expect something, the patient developing a cardiac toxicity. It's not a cumulative toxicity which we see for anthracyclines or maybe for trastuzumab. So even the first dose of, say, pembrolizumab, the patient comes after 2 or 3 weeks with severe breathlessness and myocarditis. We had one such fatal case in our practice also. So these are all the common factors. The common factors are in the center, and based on everyone knows this, I will not go then. But there are certain risk factors here. On the left side, if you see, the commonest risk factors with the highest incidence of cardiotoxicity, the hypertension, if the patient has received some radiation therapy along with immune checkpoint inhibitors, and so on and so forth. If it goes down, various risk factors based on the incidence of cardiotoxicity and the hazard ratios. I think this was again dwelt with by the previous speaker here, and this is a review again showing the global meta-analysis showing the incidence of cardiotoxicities. More than 58,000 patients were there, and the incidence of cardiotoxicity was about 3%, and the relative risk based on the type of IO was higher in case of PD-L1 about 1.3 versus say 1.32 for anti-PD-1. A dual is much higher, 1.54, followed by the targeted therapy, which is say immune checkpoint inhibitor and a targeted therapy, as we use in atezolizumab plus bevacizumab. That's an example of that. So one other thing is sometimes the cardiotoxicity is hidden behind certain other symptoms. For example, I just show you one is the non-cardiac adverse events. This is what is known as the immune-related myositis, myasthenia, myocarditis syndrome, and what is known as the IR-MMM overlap syndrome. The patient usually presents with symptoms of myositis, so fatigue, hoarseness of voice, ptosis, diplopia. And this is a review which was published last year. Only 50 cases of this MMM syndrome were published, or this was all individual case reports. We don't have any series. And I had one of these cases also in my practice here. So what they say is that the commonest the disease, you can say, is the melanoma, lung followed by the RCC. The median time to develop ICI toxicity is about 21 days, and there's a ratio also here. The most common symptom was ptosis, dyspnea, and myalgia. So if you have a patient with ptosis, dyspnea, and myalgia, usually now in my practice, I specifically ask the patient whether he has got breathlessness, he's getting fatigued, and specifically look for the cardiac toxicities. The most commonly used ICI in this study was pembrolizumab, about 40% cases, followed by nivo and ipilimumab. What is surprising, the biomarkers were raised only 2/3 of the cases, and this was the typical biomarkers of the myositis, myasthenia, as shown here: CPK, anti-MuSK, anti-cholinergic receptor antibody. So whenever you have a patient with myositis, myasthenia, always look for raised cardiac enzymes, NT-proBNP and troponin I, because that could be an underlying myocarditis also, and you may miss that myocarditis with a high mortality of 40 to 50%. Rather busy slide, but this is my personal experience in from January 24 to September 25. All the various grade 3, grade 4 toxicities are shown. These are about 130 or 35 patients now, all with standard dose immunotherapy, not the low dose immunotherapy. And all of them had developed grade 3 or more toxicities. And the circled ones are the patients having myocarditis. The last patient, the third one here, is the one who had the MMM syndrome. And as you can see on the extreme left, all of these patients with myocarditis have died. So one has to pick up myocarditis very early on. It is a high mortality rate. Of course, all of these patients were given high dose methylprednisolone 1 gram per kg, in high dose for about 4 to 5 days. Still, all the 3 with myocarditis have expired. And incidentally, all of these grade 3 toxicities have undergone what is known as the CHE, that is what we call the catastrophic health expenditure, which has been defined by World Bank. So apart from the, there are other hidden costs, there are the monetary costs of having grade 3, grade 4 toxicities. How to mitigate these cardiac toxicities? So in my practice and based on the guidelines of the European Cardiology Society, I do a baseline ECG, a stress 2D echo, and cardiac enzymes before starting of immunotherapy. ECG at every cycle, there are some data where there is a slight prolongation of QTC. You can probably predict development of a myocarditis. A 2D stress echo after every third dose based on the guideline again. If the patient is asymptomatic or maybe earlier if the patient develops some symptoms. And I do a cardiac enzymes with CPK every third or fourth dose. And what is most important is the detailed history. I really have to sit down with the patient, and at every OPD, I specifically ask whether he is getting tired, fatigued, has got any dyspnea or any body aches. Many times the patients and the oncologists also trivialize these symptoms. हम usually बोलते हैं कि ये हो जाता है, कैंसर में होता है ऐसा, कीमोथेरेपी ऐसा होता ही है. But you should really go and ask him. Typical case examples, a few patients, they have been able to walk for about a kilometer or 2 kilometers. After 1 or 2 days, 1 or 2 doses, you ask them, अभी 200 मीटर या 200 फुट चल सकता हूँ, अभी थक जाता हूँ. Typical symptoms of maybe myocarditis, maybe myositis, and you have to look into it. So there is a hidden toxicity in many of these patients. Thank you.
Thank you very much for the excellent talk. Could I ask you a question? Like, why do you do cardiac enzymes? I mean, CPK I understand, and you're doing troponins as well. But why do you do a cardiac enzyme? And any reason for doing a stress echo? Is it just you want to see like whether there any
So as per the recommendation of the European Cardiac Society, now it is, I think, recommended, I would like to have inputs from others, that we do a stress echo in all the cases, especially to detect early myocarditis.
There's something wrong with that, I think.
Yeah.
Yeah.
Absolutely. That's part of the reason for my question.
See, the effort intolerance is very common. That's the easiest, the earliest sign of immunomyocarditis. Effort intolerance. Patients say they can't just do. But doing stress echo, I think there is something wrong with that.
Do you do stress echo at every
we don't,
cycle?
No, not at all. It's not, stress echo is not going to help. The 4 things which really works with them is baseline ECG, cardiac troponin, then strain rate imaging, and the clinical pictures. These 4 things can let you diagnose immunomyocarditis in 94% of the patients. Typically, many of them will present with a disease looks like disease progression. So we have to teach the patient and the relative that in case you develop excessive fatigue, breathing difficulties, of some kind of chest pain, please report. And you can, if you have a baseline troponin, baseline GLS done, you can compare with that. That will help you make a diagnosis.
But would doing cardiac enzymes as such add anything to it?
Yes,
I mean,
yes, definitely. Because these patients, if you have a baseline troponin, especially high sensitivity troponin, the moment it starts racing, you can be suspicious. But that's not an indication to stop. See, phylogenetically speaking, every myocarditis will have an elevation of the immune checkpoints. So if you unleash the immune system, it is a plausibility that it's going to occur with everybody. Some amount of cardiac involvement will be there in almost every patient who is given immune checkpoint inhibitor. But that not translate into clinical effects. You need not stop. That's why the speaker was saying, like, if 70% of the patients suspected even was not given immunotherapy. That's that particular scare. But in immune checkpoint inhibitors, 33% of the patients will have, as you said, negative enzymes because they develop stress-induced cardiomyopathy.
Right.
And they will not respond to steroids.
okay. So we are already running very late, so I'm being asked to maybe move on to the next last speaker, Dr. Rakesh Gopal. Thank you very much, Dr. Alurkar. So the last speaker would be in this session, Dr. Rakesh Gopal. He's a cardio-oncologist of the Chennai Cardio-Oncology Group.
Okay, I think there was some communication problem in this. I was given 2 topics, and this topic was sometime later. It's good that it came with this. It's for the cardiologists basically. uh, if I say this to oncologists, they may not really like to hear, but say evading immune system is one of the hallmarks of cancer. If you are really interested, please read The Hallmarks of Cancer by Weinberg, first published in 2000, again repeatedly published in 2011 and then 2022. So some way the immune system has to be evaded by the cancer cells to establish themselves as cancer. So if you use, there may be different kind of immune checkpoints involved in PD-1, PD-L1, CTLA-4, but somehow this, when you unleash the system, it leads to cure of cancer in many of them. At the same time, it can hit the thing. I mean, it can really hit the heart. If you use this is really a part of the, as Dr. Pravesh said, about saying different agents. If actually speaking, if you use one single agent as treatment, the chances that the patient develops a significant immune myocarditis is about 0.5%. If you use two agents, it's about 1.4 to 1.5% alone. So patients with diabetes, heart failure, and prior acute coronary events are more at risk. Older age, higher BMI again puts the patient at risk. And one of the most risky cancer to treat with immune checkpoint inhibitors, even though the benefit is high, is the thymic epidermal tumors. They are the ones who develop one of the worst kind of myocarditis, and survival can really be difficult. I really didn't want to go to these mechanisms. This comes related to the topic. Troponin I, as so just being asked. The best predictor of severe toxicity is the cardiac troponin T. If there are more than 32 times elevation of the baseline, there is more than 11 times risk of MACE in them. It is actually just affecting only the heart. It also affects the skeletal muscles. So if the cardiac troponin T is elevated, that means the patient is at risk of death because they do develop more heart block and ventricular arrhythmias. They have relatively preserved ejection fraction, unlike in troponin I, where the cardiac ejection fraction may be lower. There may be more severe immune-induced myocarditis, but less severe involvement of skeletal muscles. And just the previous speaker spoke about the myasthenia. See, myasthenia is almost inevitable in patients who die of immune myocarditis. If the immune myocarditis comes, and if the patient starts becoming more and more sick and more breathless, that means myasthenia is on the way. Be prepared. In these patients, they require ventilation, and they may require a high dose steroids to prevent death. Then SST2, is a biomarker for inflammation and fibrosis. 44 nanogram per ml. There's a high likelihood of poor LV function and patient to be in the class 3 and class 4, and the risk, though outcome may not be much different. Why this matters, if you look at the markers for inflammation, is that ICSI-induced myocarditis, though the incidence is very low, something like 0.5 to 1.5%, the risk of death is very high. It may be up to 49% to 50%, but in some of the series it will still be higher, more than 60% to 70% too. So troponin I, what are the strengths? Troponin I is highly cardiac specific. So if you think a patient is breathless, if you want to know whether it is myocarditis or something else related to infection, related to non-immune myocarditis, then you can use cardiac troponin I. But it will definitely miss the skeletal muscle involvement because troponin I is typically cardiac specific. So in them, what is going to kill the patient more likely is that the involvement of skeletal muscle and also the involvement of the myasthenia gravis. Troponin T is more sensitive, but it is less specific for cancer, for the heart. But troponin T is also elevated in patients who develop immune myocarditis when there is a coexisting skeletal myositis. So when you want to look at whether patient has got something like unrelated muscle necrosis, which can also make the patient breathless, And if you want to know whether it's a coexisting myocarditis, then you can depend on troponin T. CK and CKMB, again, if you have suspicion of someone becoming breathless, and if it is due to rhabdomyolysis or primary muscle injury, you can look at CPK and CPKMB. CPKMB alone is more common in cardiac, but part elevation of CPK is common with rhabdomyolysis. NT-proBNP is not actually a marker of an early involvement of the heart. It means heart is already involved. Patient is in heart failure. You are in doubt whether it is an immune-related injury to the lungs, or there is an infection, or something else which makes the patient breathless. Then you can do an NT-proBNP. If it is elevated, it means there is definite heart failure. There is no doubt. ST2, it reflects fibrosis and inflammation. It's an excellent marker of poorer outcomes. Limited availability, but I don't think it is more so. Recently, it's become much more available even in our labs. It can actually be done. It predicts both elevated dysfunction and higher class of involvement of the myocardium, class 3 or class 4. Now, is there any good thing? Do you have any marker which actually predicts a better outcome? Yes, CD69. It was presented in the last European ESC Cardio-Oncology meeting in Florence. It's a lower baseline CD69 expression linked to a twofold higher risk of cardiovascular disease. And early detection in T regulatory cells, CD69, in the first 3 weeks indicates loss of peripheral immune tolerance. That means patient is more prone to get more problems if the CD69 is actually low. The clinical implications, CD69 expression may help identify high-risk patients and guide closer monitoring in them, and personalized intervention is related to prevent further cardiac injury. So immune profiling before ICI therapy can actually be done in these patients to predict who is going to develop more severe disease. CRP is a marker of inflammation. In a patient who have immune myocarditis, if CRP is elevated, that means there is an increased risk of thrombosis. At least 10% of these patients will or are likely to develop significant peripheral DVT, and they are prone to develop embolization and possible death. As ST2 as a biomarker for inflammatory cardiomyopathy, it reflects the LV impairment and predicts mid and functional status of the ICM, but may not really be the death. This study about 100 patients, immune-related myocarditis and immune-related myopathy, there was significant elevation of the troponin T versus troponin I, and isolated immune-related myocarditis, NT-proBNP is elevated, which is associated with decrease in the elevation fraction and also more of heart failure. The mortality was only numerically high in immune-related myopathy compared to immune-related carditis alone. I don't want to go to the this was discussed in the previous thing. I don't want to go to this again. The key messages: immune-related cardiac injury, particularly myocarditis, is rare but life-threatening complication of treatment with immune checkpoint inhibitors. Cardiac troponin I and T are sensitive biomarkers, but troponin T is less specific, more sensitive. Troponin I is more specific, but it may not be less sensitive enough because troponin T elevation occurs earlier compared to troponin I. So if you think there is more myocarditis, less skeletal muscle injury, troponin I is a choice. If you think skeletal muscle is going to be involved or there are signs of some involvement, troponin T is better in them. You can add CPKMB to it. Thank you.
Thank you, Dr. Gopal, for the excellent talk, but I don't think we would have time for questions. Maybe if you have any question, you can ask him during the break. Is that all right? So let's end this session here. Thank you very much. Thank you to the speakers.
Thank you so much, sir. We'll now move on to the next part of the session. I invite our chairperson, Dr. Shirish Alurkar, who's the head of Department of Medical Oncology at HCG, Asta Cancer Hospital, Ahmedabad. Over to sir to introduce our speakers.
it's going to be a sort of curtailed session because there are two talks are cancelled. The first speaker is Dr. Srijata from Kolkata. She'll be talking on the role of steroids in IO-induced myocarditis and the changing paradigms in steroid refractory myocarditis.
Good evening, everyone, and thank you for giving me this opportunity to the organizers. I'll be talking about steroids in IO-myocarditis and evolving paradigms in the treatment of steroid refractory myocarditis. This is a publication in JACC Cardio-Oncology this year, and we'll be talking about this in more detail, particularly the role of steroids. So brief background, as we all know, immune checkpoint inhibitors are used in multiple oncology indications, lung cancer, renal cell carcinoma, plenty of indications. And we also know that immune-related adverse events are a well-known side effect of this class of medications, predominantly thought to be due to a loss of self-tolerance, leading to a kind of an autoimmune inflammatory response in the body. Both pericarditis and myocarditis have been reported. The incidence of myocarditis is around 1%. However, the mortality is very high, around 50%. The mainstay of treatment of myocarditis as of today is the use of steroids. However, due to the number of side effects of these steroids, non-steroidal agents are also now being used. So this table kind of summarizes the essence of this viewpoint article. It tells you about the nuances of using steroids. I'll go over the differences between guidelines from various societies like the ESC, ASCO, SITC, and NCCN. There are some common points and there are some differences. So in terms of initial dosing, almost all the guidelines recommend starting with high dose steroids, meaning 500 to 1,000 milligrams per day, preferably IV methylprednisolone, given for about 3 to 5 days. The only difference is, as you can see, ASCO, they recommend starting with a lower dose of steroids, around 1 to 2 milligram per kg per day, and then if there is no response, and this is a very, there's no clear-cut guidelines by what they mean by response, but if there is no initial response, then they recommend stepping it up to pulse dose steroids. This publication is done by the MD Anderson group, and the last column kind of shows you their approach. So they recommend pulse dose steroids again for 3 to 5 days. In terms of timing, all the guidelines are the same. Start as early as possible, preferably within 24 hours of presentation. Same with the MD Anderson group. In terms of duration, as I mentioned, ideally for 3 to 5 days, according to almost all the guidelines, followed by a taper of the steroids. The taper duration is typically 4 to 6 weeks in most guidelines, but ESC recommends a much longer taper. I think it's 17 to 20 week taper. And the MD Anderson guidelines actually gives you a recommendation or sort of a suggestion on how you can do this taper over the course of a few weeks. Now, if there is an initial response, but say the troponin is not trending down, the LVEF is not recovering adequately, MD Anderson recommends you can add on steroid-sparing agents, other immunomodulators at that point in time instead of continuing with high-dose steroids. So this is that last point. They are saying that you can add on in steroid refractory cases. Also, if the patient presents with initial, what we call fulminant myocarditis, presenting with hemodynamic instability, in that case also, we can start with immunomodulatory agents. Just a few points about each of these parameters when it comes to using steroids. As I mentioned, the definition of response to steroids is a little bit unclear. There are no clear-cut definitions. Particularly when it comes to troponin reduction, there's no threshold, like it has to go beyond or below this particular level. Instead, what we prefer to see is a decreasing trend in terms of troponin levels, either done on a daily or an every other day basis. High-dose steroids are recommended, and this is one study, one retrospective study of about 126 patients that showed that the incidence of MACE, or major adverse cardiac events, was less if high-dose steroids were used as compared to intermediate dose or low-dose steroids. In case of that, that overlap syndrome that one of my colleagues mentioned, where you have myocarditis and myasthenia gravis overlap, typically steroids are not preferred because of a risk of respiratory failure requiring mechanical ventilation. But according to these authors, if the patient presents with fulminant myocarditis, which has life-threatening features, it is preferable to use high-dose steroids even with the risk of possibly requiring mechanical ventilation. I talked about the early administration within 24 hours of presentation. If the patient is asymptomatic and high sensitivity troponin is being used at a majority of institutions, there is a chance that there will be a little bit of overdiagnosis and overtreatment in these cases. So MD Anderson recommends establishing a confirmatory diagnosis, either with biopsy or cardiac MR, before starting treatment in these asymptomatic group of patients. We talked about 3 to 5 days of pulse dose steroids, followed by the 4 to 6 week taper. Now, if cardiac function does not return to baseline, even after 3 to 5 days of pulse dose steroids, what do you do then? Well, this group is recommending adding on non-steroidal immunomodulatory agents. So I'll talk about that in a future slide. Because we are using high-dose steroids, they actually recommend PCP prophylaxis with antibiotics. Calcium vitamin D supplementation is not recommended in this case because it's only a 4 to 6 week, which is considered a short steroid taper. So what about these non-steroidal drugs? Two main indications, steroid refractory cases or initial presentation with fulminant myocarditis. Agents which can be used or procedures which can be used include things like plasmapheresis, intravenous immunoglobulin, ATG, and a number of medications. I've given a list over here. We'll talk about abatacept in particular because there are some ongoing trials regarding this medication. And one particular prospective study looking, I think, about 30 patients used upfront abatacept with ruxolitinib and low-dose steroids in the upfront setting, and they showed that they had lower mortality as compared to use of just high-dose steroids alone. So let's talk about abatacept. One of the major phase 3 studies which is ongoing is this Atrium study, which is the abatacept for immune checkpoint inhibitor-associated myocarditis study. This is a phase 3 investigator-initiated, randomized, placebo-controlled study, mainly looking at the efficacy and safety of abatacept compared with placebo in hospitalized patients with myocarditis. So this is the basic study schema. So the study is mainly looking at adults 18 years of age and above who have a confirmed diagnosis of ICI myocarditis and are being treated with an FDA-approved immune checkpoint inhibitor. Exclusion includes an active infection and any prior exposure to abatacept. Approximately 390 patients are going to be recruited, and they will be randomized 1-to-1 between 2 arms, either corticosteroids plus abatacept at a dose of 10 milligrams per kg, or corticosteroids and placebo. And the dose of the study drug will be given as an initial dose, followed by 24 hours after that, 14 days after the initial dose, with an optional 4th dose, which can be given 28 days after the initial dose. And the primary endpoint will be major adverse cardiac events, which the definition is, as you can see on the slides. I'm going to just skip the rest of the slide in the interest of time. The other study is the ACLIS study. Now, this is a phase 2 dose-finding trial of abatacept. So what is the most appropriate dose of abatacept to give in the frontline setting? The study schema, this is the one provided by the authors. It's a little bit cumbersome, so I'll just tell you the brief points. The study has 3 arms. Arm A is looking at 10 milligrams per kg, B is 20 milligrams per kg, and C is 25 milligrams per kg of abatacept given IV. This will be added to standard of care, which in this particular institution includes prednisone and ruxolitinib. The doses will be given on day 0, 5, 14, and another optional dose will be given at day 21. The primary outcome assessment is this proportion of patients with an adequate circulating monocytes with a CD86 receptor occupancy saturation more than 80%. What this is a pharmacodynamic biomarker of activity of abatacept. And the goal is to find the lowest dose which can achieve the CD86 RO more than 80% within the first week and maintain it sustainably over the first 21 days when the primary outcome will be assessed. This is the same thing, just what investigations are to be done, etc. So coming to the take-home points, if you have a patient with ICI-induced myocarditis, start with high-dose steroids as early as possible. Go with pulse dose steroids for about 3 to 5 days. If they remain refractory after 24 hours of steroids, add on other steroid-sparing immunomodulatory agents. If they respond to the steroids and there's a proper adequate response, downtrending troponin, etc., start with a 4 to 6 week steroid taper. If they are responding, however, cardiac parameters are not returning to baseline,
even after you've completed 3 to 5 days of pulse dose steroids, then you should consider adding on immunomodulatory agents, including abatacept, etc., as I mentioned. Now, can immunomodulators be used in the frontline setting? That is being studied in these two trials, Atrium and Atlas. That's it. Thank you. I'll take any questions.
I think what we'll do is we'll have those questions in the panel. I think Dr. Randeep will be covering. So in interest of time, we'll skip to the next session. Dr. Rajiv from Kolkata again will be talking on the re-challenge dilemma. Do we re-challenge the patient after significant toxicity with an IO?
I think I have to be very fast. We are much delayed.
You said about the steroid used by Anderson. Which year it was? 25. Anderson recommending steroid used in early myocarditis? Is there an indication to treat like that? Yeah, but thing is like no, those, moment you're ready, please tell. The reason is like in low, high dose steroid is useful only in severe immune myocarditis, and second line of drug is mycophenolate. Yeah, it's not, I think that is an old data. I know, that is why I asked which year it was. I know it is.
So we recently did a systematic review presented at GCOS as well as British Cardiovascular Summit. 17 studies, real-world evidence clinical trials, as well as 588 pooled patients. So it was within 24 hours, cut the immunotherapy and go ahead with 1 gram. So 3 studies went with 1 gram, a few differential doses, but majority was with early. And that had correlations with MACE as well, good correlations.
The severe case of immune myocarditis, at least unless they receive 800 milligrams of corticosteroid, hydrocortisone, methylprednisolone, they're not going to survive. So there's a definite point in starting it into 24 hours or even earlier, if it is severe. But asymptomatic myocarditis is very common, and the smoldering type of immune myocarditis is also very common. Both of them are not associated with
Dr.
bad
Gopal
outcomes.
will have a discussion in the panel. Yeah, please, Dr. Rajiv.
Yeah, thank you. Sorry for the delay. Well, we are already discussing so much about toxicities, but what about re-challenge? Let's say a patient has severe re-challenge. So this is a paper that delves into that clinical scenario. I will go very fast. It's a 73-year-old man who was diagnosed with a metastatic squamous cell carcinoma of unknown primary. PDL1 was 80%. He received first dose of pembrolizumab in combination with paclitaxel carboplatin. Just after receiving the chemotherapy and immunotherapy, the patient in a couple of weeks' time reported general fatigue and lower limb muscle weakness. Soon after, he described oculatosis, generalized neck flexor weakness, and progressive dyspnea, for which he was admitted for further workup. One day after admission, the patient went into complete AV block, and cardiac markers were elevated. His shortness of breath worsened. He needed all-day non-invasive ventilation. An endomyocardial and a peripheral muscle biopsy were performed. Histopathology showed histiocytic infiltration of both tissues, myocyte necrosis, suggestive of immune checkpoint inhibitor-induced myotoxicity. Cardiac MRI was done, which was consistent with myocarditis. Ejection fraction was 67%. So this is where a chronological aspect, we will focus on the left-hand side. So this was after giving chemotherapy and immunotherapy, the patients, as you can see, that the toxicities develop. And this is where in the initial part, in 40 to 60 days, there was arrhythmia, there was that required a temporary pacemaker and then a permanent pacemaker. Ejection fraction was still more than 55%, and as you can see, the cardiac markers were elevated in the 40 to 60 day limit. So he was treated with steroid, initially with methylprednisolone at a 1 milligram per kg dose, then it was transferred into oral dose. They also, ruxolitinib and abatacept was also used in this patient. So after 3 months of the first pembrolizumab, the FDG PET CT scan shows a complete oncological response. Just of 1 dose of immunotherapy did the trick. But there was an intense hypermetabolism of the neck, diaphragm pillar and left infraspinatus muscle, and more moderate uptake at the intercostal muscle levels were noted in keeping with active ICI myositis. Over the following 4 months, the patient's myositis-associated symptoms diminished notably, his ventilation requirements slowly reduced, his cardiac conduction system never recovered, and he remained fully dependent on his pacemaker. Cardiac MRI almost 1 year after the myocarditis revealed an asymptomatic, slightly enlarged left ventricle with septal hypokinesis, and ejection fraction was now lowered down to 48%. After 1 year, a PET CT scan was done which showed relapse. Now we have to treat the patient again, and we can't dare to think about immunotherapy, right? So in second line, he received paclitaxel carboplatin, progressed very soon. Third line, FOLFIRI, again progressed. So there were chemotherapy refractory, in fact. So then what all respectable oncologists do, they call for a multidisciplinary tumor board, and there it was decided that let's dare to take up this with another round of immunotherapy. So immunotherapy, nivolumab, was rechallenged considering 22 months after the patient's first dose of pembro, and within first 3 weeks of rechallenge, the patient's troponin T level increased progressively from 496 to 496, and NT-proBNP to 3849, troponin I 48, and CK 492. So the symptoms, the markers were elevated. So cardiac MRI showed a stable but mildly reduced ejection fraction, 48 to 46%, with abnormally elevated septal T1 mapping. Holter electrocardiography revealed bursts of asymptomatic non-sustained ventricular tachycardia. A peripheral muscular biopsy was done which showed chronic sequelae of the patient's previous myositis episode and acute inflammatory changes, confirming the recurrence of the ICI myotoxicity. Prompt treatment again with abatacept, 3 doses in total, ruxolitinib and a corticosteroid was started, and after 6 months FDG PET showed complete cancer response. So what are the recommendations? So right now ASCO is very conservative. They say that any sort of myocarditis in these patients, you should just discontinue permanently any rechallenge with immunotherapy. NCCN says that if it is grade 1, then you can consider rechallenge, but if it's higher, then stop. And European Society of Cardiology says that cardiologists are slightly braver, so they decide that you have to decide on the severity of myocarditis, whether any alternative treatment options are present or not, with what is the stage of the disease, and if you are using dual immune checkpoint blocker, then you can try out single immunotherapy. So what are the problems with abatacept and ruxolitinib? I have never used them personally speaking, and the major challenges are accessibility and cost, proper knowledge of the immunology to safely administer and titrate each agent in a specific order, fatal side effects such as myelosuppression and sepsis. And so what the authors did, I think they calculated the risk and benefit ratio. They were routinely monitoring the troponins, TROP-T and TROP-I, also other cardiac markers. TROP-T is a more sensitive marker. In one, the same group, they did another analysis and they found out that TROP-T is more sensitive than TROP-I, as we have already discussed. And TROP-T more than 32 times upper level of normal was associated with approximately 11-fold increase in the risk of major cardiomyotoxicity complications. My takeaway from this paper would be that an ICI rechallenge is feasible even after severe immunotherapy-induced myocarditis, but it has to be highly monitored by an experienced team in an appropriate situation and after thoroughly analyzing the risk and benefit of the approach. With that, I thank you for your patience hearing.
So a very controversial approach, I mean, rechallenging. At least I wouldn't have the guts to rechallenge with such a disease, I mean, such a toxicity. Dr. Vivek, would you like to, I think you want to say something?
So, sir, you know, when oncologists, as oncologists, we run out of treatment options. And when you know that there is an effective treatment which can save the life of a patient with such a prompt response that even a single dose can give you, you know, a complete remission for months and all, then I think, you know, with the advent of these newer immunosuppressive treatments like abatacept, like ruxolitinib and all that, of course, with experience and monitoring, this is the way out for these patients. Of course, MDT is definitely needed, and appropriate counseling is needed. There is risk associated with it, But if you are not giving anything, you know that nothing is working in this patient except immunotherapy. So I think on those fronts, as oncologists as well as cardiologists, we need to be brave in those situations. There are case reports like that. You know, there is an Indian case report even that you know, after a severe pneumonitis, you know, the patient was continued re-challenged with immunotherapy, and they continued tocilizumab along with it. So there are, these are interesting reports that are coming up where you are continuously you know, using an immunosuppressive so as to prevent the IRA, but you are still using an immunotherapy and still having anti-tumor action. So these are pretty non-conventional things, but maybe with the, you know, advent of time, we'll have more and more data on these. But these are really you know, interesting aspects, and that is the reason why I wanted to bring this case into discussion. Thank you.
I think the most important thing is awareness, and I think the Cardio-Oncology Society is doing wonderful job at raising awareness for oncologists like us. Thank you.
Really hats off to you because it's a fantastic case. And the way you are treated is really, really good.
So,
and one point I want to tell you is that the symptoms came so fast. Usually immune myocarditis takes about 4 to 6 weeks time. The earliest which comes to other immunotherapy is that, you know, Cartsil. Cartsil comes in about 7 days. But this is a florid response which came, and you treated it, and the patient had recurrence and tried again. Fine, it's fantastic. That's the way it should be, the way science is. Very good.
yeah.
I think we go to the next session.
Thank you so much, sir. It gives me great pleasure to introduce our next chairperson, Dr. Arjun Ghosh, who is a consultant cardiologist at Bird's Heart Center, London, UK. I now invite Arjun sir to please introduce our speaker. Over to you, sir.
Thank you very much for the introduction, and thank you for the invitation to come and speak today and to hold this chairing session. So I have great pleasure to introduce Dr. Shuvra Banerjee, who's a senior consultant interventional cardiologist at Apollo Multi-Special Hospital here in Kolkata. He will be speaking on cancer-related immune therapies, bidirectional implications from cardiotoxicity to emerging cardiovascular therapeutics. Thank you, Shuvra.
So thank you, Dr. Ghosh, and good evening, everyone. Could I have my slides, please? Is there? Well, I can't see it here. Can I see it here as well? Yeah, thank you so much. Okay. So a bidirectional relationship exists between cancer and cardiovascular diseases, exemplified by a higher prevalence and incidence of cardiovascular disease in patients with cancer, and a higher prevalence and incidence of cancer in patients with cardiovascular diseases. Although the mechanisms underlying this bidirectional relationships are still speculative, there are several hypotheses or postulations, I would say, such as shared lifestyle and behavioral risk factors, such as smoking, obesity, physical inactivity, shared common mechanistic pathways, such as CHIP, microbiome alterations, angiogenesis, metabolic remodeling, and remodeling of extracellular matrix. Also, CVD is linked to chronic inflammation and oxidative stress, which can create a microenvironment that promotes tumor growth and metastasis. And many cancer conditions, many cardiac conditions, for example, amyloid heart disease or carcinoid heart disease, are actually caused by cancer. And we know that many cancer therapies cause cardiotoxicity. So in essence, chronic inflammation, metabolic disturbances, and immune system dysregulation are shared pathways between these two disease entities. Now, if we consider immune dysregulation as one of the common denominators in cancer and cardiovascular disease, you would ask me, where is the evidence? Well, we know that the immunotherapies are now considered as a pillar of cancer management, and they could be immune checkpoint inhibitors or cell-based immune therapies. And ICIs, we know, are antibodies which bind to immune checkpoints on T cells or cancer cells and inhibit the off signals, thereby activating the T cells and killing the cancer cells. But sometimes overactivation of T cells against non-cancerous cells occur, resulting in immune-related adverse events. And they can involve the cardiovascular system as well, causing myocarditis, cardiac dysfunction, pericarditis, and so on. Now, in T cell-based therapies, T cells from the patients are genetically modified to produce proteins on their surface called chimeric antigen receptors that could recognize the tumor-specific antigens and kill the cancer cells. And we know that the cardiotoxicity could happen in 3 ways. It could be cytokine release syndrome, which is not directly tumor-specific and happens due to lysis of tumor cells or activation of local immune cells. And there could be on-target off-tumor effects when T cells attack host tissues that share common antigens, or off-target, off-tumor effect when T cells attack host tissues due to unintended antigen sharing. And again, cardiovascular side effects could be left ventricular dysfunction, Takotsubo, arrhythmia, conduction disturbances, cardiac arrest, and so on. So, the occurrence of immune therapy-induced cardiotoxicity does suggest that immune system dysregulation is involved in the pathogenesis of cardiovascular diseases. So, the question arises, could the same or similar immune pathways be harnessed for therapeutic benefits in cardiovascular diseases? Immune checkpoint inhibitors, we know, are also present on cardiomyocytes and vascular endothelium, and they limit immune-mediated injury, which plays a role in development and progression of cardiovascular diseases. So targeting these immune checkpoints holds promise for preventing or potentially reversing cardiovascular disease progression. And we know also that targeted immunotherapies, such as CAR T cells, may offer new approaches for treating pathologically expressed antigens in cardiovascular diseases. Now, in heart failure, it's seen that PD-1 and CTLA-4 dysfunction occurs, which causes autoantibody production against beta-1 adrenergic receptors, causing downregulation of beta-1 receptors, which worsens the contractility. Similarly, CTLA-4 dysfunction could prime native T cells to cardiac antigens. So these checkpoints could be targeted for favorable cardiovascular effects. Fibroblast activation protein is a marker of activated fibroblasts, which play a key role in cardiac fibrosis. So CAR T cells therapy may be used to eliminate this FAB-positive fibroblast and prevent and reverse maladaptive cardiac remodeling. With respect to anti-atherosclerosis, or rather with respect to atherosclerosis, it's been seen like PD-1, PD-L1, and CTLA-4 suppression it suppresses activation of T cells within the macrophages, and it slows down the plaque formation and enhances plaque stability. Abatacept, which is a CTLA-4 analog, has been shown to reduce plaque size. Now, CD40L is an immune checkpoint which promotes atherosclerosis, and so its inhibition protects against plaque development. And CD47 pathway has been shown to promote atherosclerosis, and so targeting CD47 pathway may help plaque stabilizations. So all these are from preclinical studies. There's no clinical study to show the effect yet. So in conclusion, it could be said that bidirectional relationship exists between immune-based cancer therapies and cardiovascular outcomes. Emerging evidence reveals complex immune cardiovascular crosstalk driven by dysregulated immune signaling. Repurposed strategies such as CD40L inhibition, CD47 blockade, CAR T cell therapy targeting FAB-positive fibroblasts, all these have potential for treating cardiovascular diseases. Therefore, immune checkpoint modulation and CAR T cell therapy represent promising new strategies for the treatment of cardiovascular diseases. Thank you.
Any questions?
So just like a personal opinion, sir, that this is really an intriguing field that when we are talking about immune therapy related cardiotoxicities, we can also harness these immunotherapies for treating cardiovascular diseases itself. So how do you, sort of see this era of, science developing in cardiology itself?
Yeah, I think this is a very something very we have to be very optimistic about it. Still, it's a very in the preclinical stage. So we think if the mechanism can be reversed, then probably we can actually find benefit in protecting the heart from many other diseases, not only cancer. And I think it would also be interesting to say if we do that, does it actually increase the chance of cancer? That's also something we have to look into. But I think it's a very interesting field. I don't know how many years it would take, but I'm sure it's the future.
Yeah. So another aspect that I just wanted to discuss is that you have patients who had immune-related cardiovascular events, and then you treated them well with immunosuppression, and they survive. Now, when you follow up these patients, and they are surviving for more than 5 years now, 10 years now, and there is good data now available on these patients. So how do you look into the survival of these patients in terms of long-term, cardiovascular diseases in these patients? You expect them to have higher cardiovascular diseases, lower cardiovascular diseases, or a particular spectrum of cardiovascular diseases on long term?
Yeah, I think one paper was discussed today which showed that patients who have survived, who had not severe, but maybe less severe and survived your myocarditis, they too have problems. But probably it's not that we should forget them, but probably those who had a severe form of myocarditis and survived, they are the ones who are more prone to develop cardiovascular diseases. But very interestingly, I think it showed that even those who had low risk myocarditis and survived, they also had a higher long-term mortality. May not be high, but probably was as the same as similar to what those who had a severe ones long-term.
1 year it was same. One year outcome was same in both of them. But so there's one point, because the inflammation is the cornerstone of this, and also we have this interface of CHIP, the clonal hematopoiesis of intermittent potential, which has the propensity to have either cancer or nothing or cardiovascular disease. So if you unleash the inflammation to target the plaques, so there is a problem there because we know the plaque inflammation is cornerstone for acute events. So the acute events you can't probably prevent by doing that, but atherosclerosis can be reversed.
No, the way we are doing it.
You made a point over there.
Yeah, it's not just the reverse thing. It's what we are doing. This is the system. So there is a link between heart and your cancer, and through inflammation. So inflammatory. So your ICI, they actually causing cardiac problem. We do not go the same pathway. What we say then, we have to actually find a way to switch on the protective system, and that can be helpful. So it's not exactly the same pathway.
I think in the interest of time, we'll probably have to bring the session to a close, but thank you, Dr. Banerjee, and thank you to the audience. We'll move on now to the next session, which is the panel discussion, and I'd like to welcome Dr. Randeep Singh, who is the Director of Oncology Services in Narayana Health, Gurugram, to moderate the next session. And if I could also ask the panelists, Dr. Nandini Menon, Dr. Rakesh Gopal, Dr. Rajiv Bhattacharjee, Dr. Shuvra Banerjee, Dr. Srijata Rai Chaudhary, Dr. Shirish Alukar, and for those members to please come.
Thank you, Dr. Ghosh, for inviting the panelists. And I think we have, as the panelists are settling down, I think we have 2 cardiologists, and I can also request Dr. Ghosh to be there, and since he's already there, we will take expert comments from the chair. So we have Dr. Survo and Dr. Rakesh, the 2 cardiologists are there. And the biggest disclaimer is that I am a medical oncologist, and we are trying to learn the cardio-oncology and cardiology things. And that is the only disclaimer here. So I think this has been discussed. So what I have done in next 30 minutes is, can we change the time? It's showing 7 minutes here. We can make it 30 minutes, please. So in the next 30 minutes, we will, I think this is what is the summary, that cardiovascular events can happen from 1 to 2%. The mortality is 30 to 50%. Unfortunately, it can be there in younger patients also. The median time of onset, actually, what we never realized, even single dose to till 1 year, you can have, I have a patient with 1 month as well as 1 year of myocarditis. And yes, the ICI myocarditis unnoticed has a increased mortality. So we can start with Nandini. You, I mean, being an oncologist, we can start with you, that how does this injury happens, if you can help the cardiology fields, as Dr. Survo was also talking about, that how we can tweak this immune system. So any thoughts to your mind that why this injury is happening, what is actually happening at a level, because we know more, we have read this more in last 1 decade about how these drugs are working.
So like most immune-mediated events, the basic the mechanism is T-cell activation because of PD-1, PD-L1 and CTLA-4, and actually now multiple other checkpoints like TGT and LAG and others are also being investigated. So the whole mechanism is the activation of T-cells and infiltration into the cardiac myocytes and then subsequent immune expansion. So the balance, which is the pro-inflammatory versus the other natural balance, is kind of disrupted by our drugs which disrupt the checkpoints.
And so basically, actually, we are making that the cardiac milieu actually is becoming more inflammatory, as we want the T cells. These are the T cells which go and kill the cancer cells. And actually, when we are giving immunotherapy, these T cells are actually making that cardiac milieu or the myocytes more inflammatory. It releases lot of immune mediators, and actually these are the pathways which kill the cancer cells, and unfortunately they also affect the normal cells. And so that's why again and again the speakers and the other previous colleagues were talking about not only myocarditis but also atherosclerosis, because as a cardiologist they can correlate that this inflammatory process is pro-atherogenic, which as an oncologist we may not be able to correlate. So that is one point to be remembered, that atherosclerosis can also happen. Coming to the cardiologist, we have seen these slides because I had to summarize. So practically, we can take the comments from Dr. Survo and Dr. Rakesh. Both of you, we can start with Dr. Survo first. Sir, to your mind, when we talk about immuno-cardio-oncology, among all these factors, which are the most important ones? I mean, we know all these, the middle ones are the routine cardiac risk factors, and then on the right hand side are more of the blood parameters on the left, and we have seen this slide earlier, so I will not go through it. So practically, what is, from your, both of you, shall raise a flag to the oncologists when we think about these side effects?
See, if a patient has already pre-existing cardiovascular disease, then it's definitely a red flag.
Like someone had a coronary artery disease maybe 5 years, 8 years back.
Well, no. Say a cardiomyopathy.
Okay.
Any existing cardiomyopathy would be a high risk. If it's a coronary artery disease and active, the patient is symptomatic, that would be a higher risk compared to someone who already had a revascularization done and is stable. Someone with arrhythmias, I think that's another group we have to keep an eye on. And who has multiple risk factors. I mean, maybe hypertensive and smoker and diabetic. These are the ones also we have to be a bit vigilant about. And yeah, I think these are the ones from cardiac point of view, and I'm sure there are, Dr.
No, nothing much to add, but thing is like all these parameters, just to go through the symptoms. If you prime the patient that if you start to develop significant effort intolerance, breathing difficulty or unexplained unwellness, and then you look at these parameters, it is really important. But I have not seen the one day, with the onset of, giving immunotherapy and one day patient develop breathing difficulty is very unusual. I have not seen. We have enough number of patients, but I have not seen such incidents.
No, not one day, sir, one dose. I mean, that dose in 21 days, it happens.
One dose, I have not seen in immune checkpoint inhibitors. I've seen in CAR cell.
No, sir, it can happen. In immune checkpoint inhibitors, we have lost patients initially when we never realized what havoc they can cause. And then now we are on our toes, especially in the first 2-3 months. And you are right, it's about educating. These meetings educate us, and then we educate our patients. Earlier we were doing for pneumonitis and others, but now for cardiac also. but it can happen. I think one of Dr. Alurkar said, or someone said that with one dose he had myocarditis. Most of the times, I think it doesn't get picked up, as you said, that we are not educated enough to educate our patients that they report to us to pick it up.
Now we are actually looking for that. No, you prime the patient, you are ready to handle immune myocarditis. That's why the prognosis of immune carditis has really improved, because we have learned how to treat.
And we have to refer to you so that you realize that in the first dose also it can happen. I mean, the patient comes at the first dose, he conks off, unfortunately, and that is why the patient doesn't reaches to the cardiac call on call. Dr. Alurkar, if you have a point, sir.
Yeah, one of the interesting risk factor was absence of steroids. So do you think there will be a role of low dose steroid just to mitigate the side effects, as well as it won't compromise the efficacy of the IO?
I would, so I will not do low dose low dose steroids here, because the probability of having myocarditis is less. It is 1%, 2%, so I won't think that is a good idea to do, because even...
He asks the dose. But he asks the dose. Will you give low dose of steroid?
No, not even low dose, sir. So though we agree, so actually
the
most of
data,
the...
published data very clearly shows those people with a severe immune myocarditis who have survived are the ones who have received at least 800 milligrams of methylprednisolone daily.
No, preventive.
So I think there have been some studies where they did try prophylactic steroids. They didn't have any benefit.
It didn't work.
Yeah, I think so that as such, the idea is to pick up subclinical myocarditis. That before it gets it, we are looking for it, but I think so the modalities should be shared whereby we are picking up subclinical carditis. Because at that time, if we start early treatment, then definitely it doesn't go and land up into a fulminant one.
Yeah, 30% of the patients at least have a non-immune kind of LV dysfunction and heart failure in immunotherapy. 30%.
Maybe if I could just come back to your question, what should the oncologist be looking for? In my opinion, I think if the patient has active cardiac issues is probably one of the main things. Their risk factors, their general risk factors, blood pressure, hypertension, glucose, lipids, if all of these are uncontrolled, all of these immediately increase your risk. There is the ESC guidelines. If you look at that, there's a very easy risk factor calculator available online free. If you just go to Google Store, App Play, just download the risk calculator. Within around 2 or 3 minutes, anthracyclines, HER2 therapy, TKIs, BCR, ABL inhibitors, a lot of different drugs can be used. You can easily correct and get a risk score, which will identify the high-risk patients. Even if you don't have the time for that, just the basic risk factors, do they have cardiac symptoms, should be enough.
And actually, what is happening is that more and more combination therapies are coming in the perioperative setting, which is also becoming difficult for us as an oncologist. Earlier, these were palliative settings when we used to say, okay, this is a metastatic patient and the lifespan is only a year and you can let it go. And as Vivek said, now when these IO drugs along with the chemo combinations and others are entering into the perioperative era, and when we are looking at a survivals to the tune of 4-5%, which is as good as chemotherapy alone we were giving, on the top of that we are achieving, then it's becoming more and more pertinent to manage such side effects. Coming back again to cardiology, friends. Yes, sir.
See, picking up carditis is more of a clinical thing. It is because echo as such, if you say that echo that you have lost ejection fraction by around 5% or something, and all the sequential testing for echoes, that may not be very, very accurate too, because it would differ from one person to another too. It is more clinical than what you really think. If the patient has got high degree of, the patient starts having a lot of sinus tachycardia, he is low on the pressures and all those things, then it definitely tells upon that, okay, that possibility of a carditis setting in is definitely there.
Okay. So I think this I will skip it, but this is just to tell that there can be some other immune related which are out of the cardiac field. That is these drugs, I mean this is just a passing comment and we will go further in the interest of time, that they do cause a lot of hormonal imbalances. They causes hypothyroidism, hyperthyroidism, hypopituitarism. They do interfere with the whole endocrine milieu of the body apart from the heart, and that is also to be kept in mind as a group, both to the oncologist and to the cardiologist, that there can be indirect side effects on the heart because of these. Coming to the clinical syndrome, I think this we have been discussing back and forth, and now we can come to our medical oncology colleagues. We can ask Dr. Srijata. Have you been unfortunate to see the last one, shock, arrhythmias and AV block?
I actually have been fortunate. I have not had a case
You have
like
not
this.
been unfortunate. I have been also lucky not to see shock, arrhythmia, AV block directly presenting. But yes, sir.
I have seen enough number of patients in 2019, 2020, when we really didn't know much about immune myocarditis. I've had patients, some of the highly ranked politicians, including coming with a complete heart block. And,
directly, sir?
Yes, complete heart block and VT. These two things are deadly.
But they were not related to, because that is the COVID era and we are
definitely
not related to any coronavirus.
2019,
before that they were.
Before that. So that one of them had put down pacemaker. The last case discussed instead the complete heart block persisted. But it's when the inflammation subsides, most of the time the heart block also subsides. So when we think, why I could have put a temporary line, I do not know. But a patient in heart failure tending to develop VT, and if they tend to develop heart block, you are end of the road. You have to be very careful and you have to be very aggressively treating and don't hesitate to put a pacemaker.
Nandini, have you observed any fulminant? And Dr. Alarkar, you want to make a comment?
Sorry, just one patient had an atrial fibrillation with a combination of pneumonitis, acute interstitial nephritis in one patient only. Another patient had a fulminant hepatitis with a complete heart block. Both the patients, the other one is surviving. The CHB patient is no more.
Nandini, your experience of fulminant, I mean, we have seen dyspnea, orthopnea, I mean, and as sir was telling, I think, that we have to keep a watch of asymptomatic elevation. I think that is more of asymptomatic. But what about the others, like directly presenting with arrhythmias and AV block?
So AV blocks, arrhythmias not seen, but acute heart failure, there has been one patient and one patient with severe heart failure needing ICU support. These are the two that I have seen.
So actually my dilemma is, and this is my dilemma, sir, that when we deal with a geriatric patient who is 70, 75, we are treating with drugs like maybe immune checkpoint inhibitor along with the chemotherapy, and then we are adding a TKI, and you also being an expert in cardio-oncology, you know the TKI also causes all these side effects like acute heart failure, the arrhythmias, QTC prolongation, and there are around 15 to 20% of the patients who are on a combination of IO-TKI in the today's era. And then with this dilemma, and for us as an oncologist, it's very difficult to differentiate. We can pick up that yes, the patient is having, there is a cardiac problem. But with this whole dilemma, I mean, how to go about it? And that was, we can start with anyone, Dr. Survo, Dr. Ghosh. What do you, because we all know this is there, and I think the starting point starts with this, if I'm correct, and Dr. Ghosh can take us, and then Dr. Survo, that for a cardiologist, for an oncologist, I mean, we are aware of all this, and the moment we suspect it, how do we start it? Of course, we will do an on-call reference and others, but at that point of time in the OPD.
Yes, I think the point has been raised that the first symptom can often be very vague tiredness. So we always tell the patients that even if they just have something like that, just normal tiredness, that can be the first sign of a mild troponin rise. Now, you have to remember that troponin being positive in these patients is extremely common. That doesn't necessarily mean that they have a high-level myocarditis. It also doesn't mean that their outcome is necessarily going to be extremely bad. If we were to measure, so if you look at the registry data, the amount of patients who have troponin positive is maybe 1%, 2%. In real life, definitely the amount of troponin positive patients is much higher. However, the mortality rate in registry data is 50%. In real life, mortality rate is much, much less. Now, if you do the troponin rise, if that's elevated, alongside that, you should look at the ECG, you should look at the symptoms, do an echocardiogram. GLS is quite sensitive in this situation. GLS is often below normal. Now, depends on where you work, okay? So I work at Bart's Heart Center. It's Europe's largest heart center. We do 30 cardiac MRI scans a day. We would just do an MRI scan. Problem is with MRI, we have to remember only 50% is actually diagnostic. 50% of MRIs in ICI-proven myocarditis, biopsy-proven is normal. So to the oncologist, I would say if you have a suspicion, low suspicion, please involve the cardiologist early rather than late.
So there's one caveat to it. Like when you say that the registry, the clinical trials showed more, and then observational studies showing less, there's a difference in time frame. The observational studies are now. Say, as I said, I've seen many complete heart blocks earlier, 2019, but not now. It's because we have learned how to treat and how to recognize them. So when you say observational studies do not show it, doesn't mean the disease doesn't exist. because we have learned how to drive.
Yeah, no, I agree that many of the patients before would go on to complete heart block, and also our practice has changed. So before, we would put a permanent pacemaker in those patients that we described. So we put permanent pacemaker in patients with, heart block. Now, we would always put a temporary system, treat with high-dose steroids, treat with abatacept, because often we would see that the patient doesn't need a permanent system. So our
Exactly.
practice has changed.
So, see,
Exactly.
so my dilemma was that when we order a CT and of course a cardiologist is involved, but you also have to accept that there are not trained cardio-oncologists enough in the country to pick up that thing. And that is, I have at least, working with Narayana, which is one of the flagship cardiac, we do have cardiologists, but most of the time we realize that they are also not aware of this fulminant side effect. That's why I said that for an oncologist, apart from the symptoms and starting with CT and I, and doing an echo, sometimes we also have to do a bit of job to correlate and tell them that start looking for ICI. It can be due to ICI and ICI because, and sometimes you will not believe in the second patient was a doctor's father, no one was agreeing, and it was almost 8 hours the patient was in the system. I could not understand, and so I just gave methylpred, that just take methylpred, I will think later on.
This biopsy,
that is what, yes.
This biopsy also little be careful because immune myocarditis is typically patchy. You should be lucky enough to hit the right point to get a diagnosis.
Have you done any time an endomyocardial biopsy?
Yes,
any
yes.
3 cardiologists to prove it? You
Yes,
have done it,
I've
sir.
done 7 of them.
You have done it once.
7 of them.
7 of them, when you were suspecting it.
Yeah, but the thing is,
Okay. And
see,
all of them were positive? No.
There are problems. This is what, it's that immune myocarditis is typically a patchy disorder. So unless you hit the right point, you can miss. But if it is an amyloidosis, it's a typically diffuse disease. Anywhere you hit, if it is negative, it is negative. If it is positive, it is positive.
How many samples do you normally take? So if you're doing a biopsy,
It is
how
5
many?
to 7.
5 to 7.
5 to 7.
And and again, we have to go to cardiology. We can ask Dr. Survo or Dr. Ghosh, how helpful is this criteria? Again, the radiologist will not be aware to follow this Lake Louis criteria. I think is it really helpful in the practice? Because this is what is theoretical to my mind. To be frankly, this is from the literature I have put it.
Lake Louis criteria was developed for the myocarditis per se, but not immune myocarditis.
Yes, it is for myocarditis, so that's why the cardiologist can.
In immune myocarditis, its sensitivity and specificity is the problem. So there is no single imaging technique which can categorically say this is immune myocarditis. But you have to combine. You said 50% only can be like
So what will be
most of the time it's suggested. It's suggestive of myocarditis. We can say that.
Even if you go to the Cardio-Oncology Society, they have also referred to this criteria only finally.
So let me speak.
See, the endomyocardial biopsies will be very difficult in every setup.
So as I said, we're one of the world's largest MRI centers, right? So I do MRI on a daily basis. So the issue that you have is you can combine, so these are the newer parametric mapping systems, T1, so all fancy things that we like to use. It's helpful, but unfortunately, as I mentioned, even in biopsy proven, half the MRI scans is normal. So still it has to be by the clinical suspicion. So if the troponin is elevated, if it is in the context of checkpoint inhibitor therapy, especially combination therapy, even if the MRI is normal, if you have a high index of suspicion, there's no harm, even from the oncology side, to treat with high-dose steroids.
See, the harm is not in, I will tell you the challenge which comes to us is not
in the
labeling.
re-challenge.
When you label them as an IO myocarditis, the re-challenge becomes very difficult for us.
Absolutely.
Especially if it's a metastatic situation. Or rather it's a curative, both of the sides.
See, if none is specific, but still you have these 4 parameters, as he said, on the background of immune checkpoint inhibitors, history of extreme fatigue, and an abnormal ECG, which is newly developing symptoms, troponins, and GLS itself can diagnose in 90% of the patients. And it is not easy to put patients with a frank myocarditis for MRI. It's not easy.
I think sometimes GLS may be abnormal, but the patient may not be having myocarditis. Sometimes infiltration of the T cells itself can cause
And even GLS can be due to anthracycline. The chemotherapy-related cardiotoxicity will also cause the GLS.
We do GLS before starting immunotherapy. So that you have it at baseline.
But sir, there was a paper where the anthracyclines are being used with immunotherapy, and then there are situations where chemo is being added, and then there are situations where TKI is being added to IO.
That is exactly the GLS alone will not make a diagnosis.
Okay. I think we come back to this, and we come back to, again, Dr. Srijata, are you following this? So we are aware of this. This is ECG, echo, troponins, NP, and low risk, high risk. This is I mean, we all know this paper. This is the ESC 2, I think 2022, yes, 2022 paper. The ECG is okay, and they have done echo in a low risk baseline and then every 6 months. And then in a high risk also, the echo is done at baseline and then there is no echo in the follow-up. So what are you doing in the practice? Are you doing all these parameters at screening, and then when are you repeating it?
So
let's talk about high risk.
In high risk. So in high risk, ECG and echo we always do, and then troponin and BNP not always, not unless they're symptomatic. Typically I don't do, but ECG echo is part of the standard pre-chemo workup. This cycle 2, 3, 4, we don't do unless the cardiologist advises, we'll be honest.
What
the ECG to be done with cycle 2, cycle 3, cycle 4, along with the troponin, with every cycle. This
is a simpler thing to us. I mean, this is more like a simple thing to do ECG.
Yeah,
I think
but we don't
the
do
more
it.
thing the more which I feel I am also missing is cardiac troponin, because what I could gather from the whole discussion is that cardiac troponins are important. And that is a simple thing to do, and in the high risk they are recommending every cycle to do cardiac troponin. So are we following that in cardio-oncology tumor boards or other?
No, we don't do the 2, 3, 4, we do the every 3 cycle.
Every 3
every
cycles.
3
Okay.
cycle.
Dr. Alurkar?
ECG every cycle, every dose, because it's easy, it's not much of a thing. Echocardiography maybe every third cycle, that's what I do, every third dose, just to be precaution. And troponins again every third, not every cycle, every third dose, because of cost issues, so we can't do it every time.
Fine. So it's a practically, yes, Dr. Suru.
Yeah. I have a question. Yeah. But yeah, but if your history, sorry, if I have a lot to ask, if your history is there's nothing in the history. If your ECG is normal and if your biomarkers are normal, is there any point in doing an echo? I mean, would echo show something else? So that's.
I mean, a baseline echo is definitely.
No, not a baseline echo. I'm saying
otherwise
like
it will be symptom
in the follow-up period. In the follow-up period, but if the GLS is reduced, I would think the tropi would yeah.
Exactly. So it is like that's something we can refer it to you people early, so that you can tell us that how severe it is. That is the whole idea.
We have to keep the cost also in our mind, like it adds up.
So this is just a question, when they say that troponin might be slightly higher without having...
So I was coming to that. I know what is that level which makes you alarm. So that was my question, and I thought I will ask
like
it.
Any doubling time or any kind of...
So that is for the cardiologist, that when we have grade 1, and that is usually detected for us by troponin I, though they have written more than 100. In practice, how do you do this grade 1 thing? Then when you have no symptoms, and already the patient we have done a cardiac troponin at 3 cycles, and then we have got a value of 150. And you know, sir, better than me that cardiac troponin is such a sensitive thing. I mean,
we no longer have to be cardiologists and oncologists. We have to, at least for my cardiology residents and oncology residents, now I am cultivating a culture them to be cardio-oncologists. So there's no difference between sent to the cardiologist, sent to the oncologist. A time is going to come within the first 3 to 5 years. Almost every drug which is used in oncology today is cardiotoxic. So unless you practice cardio-oncology, you are not going to become an oncologist or a cardiologist somewhere involved in it. But we do still do interventions and do something, but an oncologist, a cardio-oncology is going to be a must.
no, sir. So if you have a troponin I only raise, which makes it grade 1 to my mind, a grade 1 is mildly abnormal screening test, no symptoms. Suppose I have done a cardiac troponin, it was normal at baseline. I have given 3 cycles of double IO therapy, and after 3 months, we do a cardiac troponin after 3 cycles, and now the cardiac troponin is, there are 2 situations, one is 50 and one is 200. All other things are okay.
See, that's what I said, phylogenetically, every kind of myocarditis or a stressful state, the receptors, the PD1, PDL1 and CTLA4 is elevated, is surfaced. So that means it's just like this heart is bracing for something. So if you unleash the immune system by giving an immune therapy, same thing is going to happen. So every patient is likely to develop some kind of carditis. I mean,
so you recommend us, what do you recommend us? Shall we continue with the...
You must continue. You must continue.
Okay, okay. So that is what I was saying with
that's why
follow.
we have the 3 categories. No immune myocarditis, intermediary, and then severe.
I think we have 5 minutes left. I will come back to Srijata. Srijata, do you agree with... So most of the guidelines, and we have heard it is 1000 mg or 500 mg, but only, this is in here, there are only the American oncology guidelines. So these are... ASCO is the oncology society which says 1 to 2 mg per kg, and if no immediate response, 1000 mg.
I've actually never seen that happen in practice.
Okay, okay.
We've only done the 1,500.
Come back to Nandini. You have seen myocarditis and handled, or we can take input from Anuprita.
So for
Since you work together, yes.
Relatively asymptomatic incidentally detected.
Symptomatic myocarditis we are treating now.
We used oral steroids in one patient, but then he didn't respond, so we shifted to 1 gram for 3 to 5 days, and then he recovered.
So I think that is also one of the messages, that you don't start with this 1 or 2 mg, which we do for all IO toxicities.
We shouldn't have any doubt about this. See, the recommended dose is 1000 milligrams.
Yes.
And there was a very bad situation where a patient who had late in the evening frank immune myocarditis, I wrote 1000 milligrams of methylprednisolone. But what happened was my clinical pharmacologist thought I made a mistake, and he gave only 100. We lost the patient in 4 hours.
So luckily, this when I was talking about this, I got 2 calls from that ICU. Are you talking about 1000 ml? Yes, I have written it 1000. Please give it. 100 was given, and then we gave 900 again. Luckily, and this is exactly what was happened that night. I got 2 calls, and they said you have written a wrong dose. Then the ICU people called us, then the cardiologist called, and then I said, no, please give 1000 without thinking. Tomorrow morning we will think.
Thereafter, I write 1000 in words, 1000 milligram.
So I think that is one message which sir is saying, that don't think, because what the oncologist is doing, I will tell you, sir, when we deal with IO toxicities, most of the time we are starting with this classical 1 to 2 mg per kg of Isolon, or the equivalent doses of methylpred, which are 1 to 2 mg IV methylpred. Yes, Vivek.
Yeah. So I remember this case where, in a head and neck cancer, post first dose of pembrolizumab, my patient landed up in, ICU with a clear ACS presentation, and with the ECG and trop-I high in ACS, and there was no, so I discussed with my cardiologist, and, he was not so aware of ICI myocarditis. So he said that it is a classical myocardial infarction. And he said that no, we cannot give steroids, because if you give steroids, then it will cause necrosis. That is, what he said, that there will be more necrosis, and there will be a risk of rupture, so you can't give. And I was telling that no, sir, it is not it is not, either it is a myocarditis or it's a IO induced. There is a clear-cut temporal association. Yeah. Yes, sir, it was a classical and then, sir, we already have that even IO related AMI can also happen, because it's a vascular toxicity also. So ultimately he did I forced him to do an urgent coronary angiography. He found that the coronary angiography is normal, and then he agreed that, okay, give steroids. But, unfortunately the patient, recovered well, but the patient went into shock after 2 days. And what I understood, that probably there was a delay in giving steroids by 1 day, which actually killed.
Apologies, sir. We have 2 minutes left. So
Yes,
request you if we can.
We'll wind up in 2 minutes, so that's why I skipped 2-3 slides, Kashish. We will come back to, let's go to Dr. Ghosh. Dr. Ghosh, 2-3 things. If someone lands directly with grade 4 or a fulminant severe, he's landing up into shock, hemodynamic instability, he's sick and he's having a complete heart block, what will you do? And second is that, how do you label steroid refractory myocarditis, and what do you do in your practice?
Yeah, no, that's a very, very good question. So I think, high dose steroids.
I will take it one. So first is that if someone lands with severe fulminant grade 4 toxicity with a hemodynamic instability.
Yeah, so if they're hemodynamically unstable, if they need temporary pacing, then that's the first consideration with heart block. They might need to go to ITU, they might need inotropic support. We would do an echocardiogram there and then.
No, diagnostically, just treatment part is we give methylpred, but it will be only methylpred, or you will directly start with 2 drugs?
No, so we start in the beginning, we would start with high dose steroids only with supportive treatment. what you have to understand is with the troponin, it can go up and down with the ICI myocarditis. So, so that will always happen. If the patient is symptomatically worsening, needing more inotropic support, then we would immediately start with abatacept. We would also give MMF, because MMF will start at an earlier, it will work quicker than abatacept. Abatacept, the dose is once every 2 weeks, so that's more of a longer term solution, but we would start with abatacept quite quickly. We would also, in some cases, you can consider exchange transfusion. It depends on whether, we've already talked about the double M syndrome, the triple M triad. If there is the triple M triad, often the neurologists are involved, there's exchange transfusion, there's a lot of different options that we can consider. I think on one of your slides you had infliximab. We would never give infliximab because that is definitely not contraindicated in any person who's got significant cardiac toxicity, especially cardiac dysfunction. So that's the one point I would make.
So in an unstable patient, I will just take 1 or 2 more minutes, 1 or 2 minutes. In an unstable patient, how fast you will add abatacept, and in a stable patient, so in an unstable patient, will it be within 24 hours after 24 hours of methylprednisolone?
Yeah, so depends on how they're doing after the steroid dose. Usually with the high dose of steroids, you will see within 24 hours, you should see some kind of improvement. If there is hemodynamic instability, we would add in MMF, mycophenolate, along with the abatacept, because abatacept does not work immediately.
Okay, fine. And I think in the interest of time, we will have to wind up. And yes, sir. Last comment, sir. Yes, please.
For the complete heart block, I said earlier I used to put a temporary pacemaker. Even I put a CRTD in one patient. But now, what I do is, in case I need a pacing, in place of putting a temporary line, I put a temporary, do a subclavian puncture and put a permanent lead, screw-in lead, as temporary one. If the rhythm recovers completely, I take off the lead.
Okay, sir.
That can be done.
I think we will have to stop it here. Thank you to the experts around for guiding us to this panel. And I think these things we have to skip all these things in the interest of time. Thank you. And thank you to Vivek for having me. Thank you.
Thank you so much, sir.